welcome to today's webinar, Newly Approved Therapies for Psoriasis and Overview. My name is Bev from Field Patient Education Programs Manager here at NPF. I'd like to introduce you to our guest moderator for today's webinar, Dr. Leslie Beth, or LB, Herbert. Dr. Herbert has a PhD in psychology, having spent years in patient journey research for chronic health conditions such as psoriatic arthritis, rheumatoid arthritis, MS, and migraine. Dr. Herbert previously worked for Health Union, where she was the Vice President of Insights Operations. Health Union provides unique content and support for those living with chronic health conditions for 40+ online community websites. Currently, Dr. Herbert is the founder and lead consultant at TerrierWorks, where she uses innovative research methods to build relationships and programs that deliver customer-centric products and services. She is also a volunteer for the National Psoriasis Foundation through the One-to-One program. Thank you, LB, for being here today.
Thank you, Bev, for the warm introduction. I'm really excited to be part of today's webinar, having myself lived with psoriatic arthritis for over 12 years, as well as having worked with hundreds of patients to understand their own experience with the disease. Today's topic is top of mind for many patients, including myself. But before we start, I'd like to go over a few items so you know how you too can participate in today's event. So we have a screenshot here that shows the attendee interface, and you're going to see a panel like this on the right side of your screen also. When you joined the presentation, you used your computer's audio. So if you hear music through your computer, it's very similar to that type of sound. If you rather have the audio come through your telephone, you can click on that button there, and it'll give you instructions on how to call in and have the audio come through there. You also have the opportunity to submit questions today using the question panel there at the bottom. We received a lot of questions in advance also, so we're going to really do our best to fit time to get to many of them after Dr. Cohen's presentation. I'd like to take a quick moment just to acknowledge our sponsor and give a big thank you to Bristol Myers Squibb for their support of today's webinar. So before we start, I'd like to share a little bit about what the National Psoriasis Foundation does. At the heart of all that we do is the mission to drive efforts to cure psoriatic disease and improve the lives of those affected. We accomplish our mission by funding research with over $30 million awarded in grants and fellowships, along with collaborative and transformational research initiatives. NPF also offers education for those living with psoriatic disease and encourages all to become involved with our mission. Learn more about the research, education, and how you too can be involved by looking at the links listed on this slide. So you see them down there through education and advocacy, and we'll talk more about the website later. Now I'd like to introduce our guest speaker, Dr. Cohen. On behalf of the National Psoriasis Foundation, we have to give him a big thank you for attending, and a big thank you to all of you for attending too. Dr. Cohen is the director of the Psoriasis Treatment Program at the Yale School of Medicine and the director of safety in the Department of Dermatology. As a board-certified dermatologist, Dr. Cohen has a special interest in treating diseases that involve the immune system, such as psoriasis and eczema. He is dedicated to treating each individual like a member of his own family and tailoring treatment to each individual. Dr. Cohen is also an assistant professor of dermatology and biomedical informatics and data science, also at the Yale School of Medicine. He's been active in dermatology research. His current research focuses on the epidemiology of skin conditions, the relationship between skin diseases and other medical issues, and the way dermatologic care is delivered. Through this research, Dr. Cohen is able to improve our current knowledge and contribute to future advances in dermatology. He's authored over 80 peer-reviewed articles on psoriasis and other topics in dermatology. Per Dr. Cohen, it's an exciting time to be a dermatologist because there are so many innovative treatments that can be used to improve the quality of lives and overall health. We'll hear today just some of those innovative treatments as Dr. Cohen provides this research update about current and upcoming treatments. So it's my honor to welcome him here today for the webinar, and I will hand it over to you, Dr. Cohen.
Thank you so much. It's truly a pleasure and an honor to be here with all of you, and I'm so glad we have so many people here attending live, and I know more will be listening in later. So it's really just a pleasure to be able to speak with you about some of the new and exciting advances in psoriasis over the last year or so, and I look forward to sharing some of this with you and then leaving some time for questions at the end too. So thank you again, and I hope this is helpful for you. So today what we're going to talk about is some recently approved systemic and topical medications for psoriasis. And those of you who follow this know that there have been a few new approvals within the last year or so, and those are some new medications that we're going to spend some time talking about. And then we're going to wrap up with a discussion of some medications that may be available soon, although they're not yet available here in the United States. So we're going to start with Deucravacitinib. Deucravacitinib is a tyrosine kinase 2 inhibitor, which is a new type of oral medication for psoriasis. This medication is taken once daily, and it was approved back in September of 2022, so not yet a year. And the brand name that it's sold under is Sotyktu. So the first question is, what is a tyrosine kinase 2 inhibitor? So tyrosine kinase 2 is a type of a protein called a JAK protein. JAK stands for Janus kinase. So if you've heard about JAK inhibitors or JAK proteins before, even though tyrosine kinase 2 doesn't have the word JAK in it, it is still a JAK, and we're going to see that in just a moment. There are many other JAK inhibitors that are being used for various skin conditions, notably conditions like atopic dermatitis or eczema and vitiligo, and more too. And there are actually some JAK inhibitors that are used for psoriatic disease, including tofacitinib, or Xeljanz, which is a JAK inhibitor that's approved for psoriatic arthritis, not for skin psoriasis, but for psoriatic arthritis. And these medications are all administered by mouth. So you might be thinking, I know a whole lot about biologics, and I know kind of how the biologics work. Maybe you've taken a biologic before, and how does this compare? I understand that, but how do I understand this in the sort of same frame? And so the truth is that while the JAKs are not biologics, they are not the same. They work in a way that's sort of interrelated with biologics, and in a way that sort of uses similar concepts to ones that we already know about from our understanding of the biologics. And so, for those who don't know, or for those who need a refresher, biologics are monoclonal antibodies. They're proteins that are made by the pharmaceutical company that are injected into the skin, and they target specific signaling molecules called cytokines that play important roles in psoriasis. And the table at the bottom of the slide reviews that there are 4 different classes of biologics that target different important parts of the signaling pathway that leads to psoriasis. And then we see a list of the generic names of the agents that fall into each of these classes. And some of these may look familiar from discussions you've had with your dermatologist, or some of you may have even tried or may currently be on one of these medications. So this is a little schematic, and there's a lot here. So certainly I don't expect you to necessarily take all of this in right this minute, but this is sort of a schematic of how psoriasis works. And so if we start at the top left hand of the screen, we understand that there are environmental factors, some of which we know well, like cigarette smoking or obesity, many that we don't truly understand very well, that come together with genetic factors in a susceptible person to create psoriasis. And when this happens, there's a cascade in the immune system, which is what you see at the bottom of your slide, that relates to different signaling molecules called cytokines, telling different types of cells what to do to create psoriasis. And as you can see, each of these biologics targets one of these signaling molecules called cytokines that we just talked about, and you can see where that is along the cascade. So that's sort of a reminder about biologics. And now with this at top of mind, we're going to jump right in and think about how the TYK2 inhibitor, or tyrosine kinase 2 inhibitor, deucravacitinib, may sort of fit into this concept that we already have. So this is a generic sort of model of how this whole system works. So if you look at the top left, you'll see a cytokine, and then that blue, those 2 blue things are the receptor. And that's how the cytokine and the receptor communicate to tell a cell what to do. This is the bottom part of your slide is showing a cell with the DNA there at the very bottom. And so the biologics work basically all at the top left-hand corner of this slide with either the cytokine mostly or sometimes the receptor. The JAK inhibitors and also the tyrosine kinase 2 inhibitor, deucravacitinib, works at the next level there. So you see that just inside the cell, there are these JAK molecules. And when the cytokine comes and binds to that receptor, it turns on this JAK sort of process here, which leads to activation, and that goes into the DNA of the cell, telling the cell what to do. And where it says there target gene transcription, you can think of that in this case as making psoriasis. So the JAK inhibitors basically just stop the cytokine from sending the message. And when I explain this to other doctors or patients, I'll often talk about the mail analogy. So that's what's shown here on the right side of your screen. So you can think of the letter being the cytokine, that's what's carrying the message. Your mailbox is the receptor, that's where the message goes to get delivered to you. And then the JAK STAT pathway, or in the case of deucravacitinib, the TYK2 pathway, is what opens up the letter, which goes down to the DNA and reads the letter and does what the letter says. It pays the cable bill, or you see what someone wrote to you in the letter. So to sort of summarize this, the biologics are working on either the piece of mail or the mailbox, whereas the JAK inhibitors, including the TYK2 inhibitor deucravacitinib, prevents the letter from being opened and read inside the cell. So you've heard a lot about these JAK and TYK2 inhibitors, and you may have heard about some being JAK1 or JAK2 or JAK3. And the idea here, and what this slide is showing, is that there are a very small number of JAK molecules, shown as those colored little ovals, that correspond to a lot of signaling from many, many different signaling molecules called cytokines, which are listed above those JAK molecules. And you'll notice that in the blue shaded box, we see that TYK2 is very important for Th17 cells, which we know are important for psoriasis. So basically, TYK2 is the one that's targeted for psoriasis. Just for the sake of completeness and interest, I included some of the important things that some of the other JAKs do, but in that blue box, that's really what we're focusing on right now to try to understand how this deucravacitinib medication is working. So now to look here and really drive this point home, we can see exactly what deucravacitinib does. So you can see that interleukin-23, shown by that little purple circle, comes and binds the interleukin-23 receptor. This may sound very familiar to you from other biologics you know, right? There are 3 interleukin-23 inhibitors that are used here in the United States, Risankizumab, which is Skyrizi, Guselkumab, Tremfya, Tildrakizumab, Ilumya, and we also have Stelara or Ustekinumab, which blocks both interleukin-23 and interleukin-12. So this is going to look kind of familiar. Then as we drop down, we see what's just inside from that. What is the opening the letter from interleukin-23? Turns out that's TYK2 right there. And so you see that red DEU, that's where deucravacitinib works, preventing psoriasis from occurring. So while it may seem like these JAK inhibitors are very foreign and a very different idea from what you've already heard and what you understand about biologics that have been used for a long time, it's very closely interrelated. And I think that this image here shows that. So now thinking about how well deucravacitinib may work in psoriasis. So there was a clinical trial called the POETIC trial, which, as you see here, compared deucravacitinib, or Sotyktu, to apremilast, which is Otezla. Many of you may have heard of that. That's another oral medication for psoriasis and psoriatic arthritis that has been around for quite some time. And you see here that what they did was they compared deucravacitinib to Otezla or apremilast. And here's what they found. First, PASI 75 is on the left-hand side of your screen. Many of you may be familiar with this. For those who are not, this is basically trying to quantify a 75% improvement in your psoriasis. So that's a pretty high bar, and we'll see how they did. So you'll see that they originally wanted to look at the 16-week mark, so 4 months on treatment, to see how well people did. The blue line, that's the highest up, showed that 58.4% of people who were given this deucravacitinib medication, or Sotyktu, achieved that, PASI 75, 75% improvement. Whereas in the Otezla apremilast group, which is shown in orange, only 35% of people did, and then the placebo group only 12.7. And you wouldn't expect the placebo group to match up to these medications that we know work well. And then as you see, as you go out to 24 months, both these medications continue to improve in their performance, but the difference becomes greater. On the right side of your screen, you see PGA, which is the global assessment, 0 or 1. That means that the doctor looked and said, this patient is either clear or almost clear. So what you kind of want, that's out of a scale of 4. And you see very similar findings in terms of how many people achieve this and also the differences that you see over time. So deucravacitinib worked well and clearly outperformed apremilast or Otezla here. Now they looked at much longer, right? So this is showing you out to 52 weeks or a whole year. And what they saw here was 2 things that I think are important. Firstly, they see that the benefit sustains. So you see that after about week 32, the line stays stable at almost 70% of people getting to and maintaining PASI 75 or 75% improvement out to the year. They also showed, as would be expected, that the people in the placebo group, showing that gray line that went on to treatment after that 16-week mark, quickly caught up and got to where people on deucravacitinib were, which is what you would expect. And again, similar trends, similar finding on that clear or almost clear on the right-hand side of your screen. Looking out up to 2 years, they found that 75.7% of people had that 75% clear at 2 years on deucravacitinib, and 56.4 were clear or almost clear on deucravacitinib. So this is showing that it works pretty well and that the benefit is sustained as you stay on the medicine up to 2 years here. So now you might be thinking, all right, this looks like it works pretty well, but how does deucravacitinib compare to biologics? And so the first thing I'm going to say is that what I'm doing on this slide, you're not really supposed to do. All these studies are slightly different. The study populations are slightly different. The way that people are enrolled and so forth is going to be different in each and every trial. And so what you see on the left-hand side of your screen is a research article that was done in one of our journals that did what they call a meta-analysis. So they use particular statistics to try to compare these, and that's okay. But what I'm doing on the right-hand side, which is to compare that directly to the Poetic trial, is not really what you're supposed to do, but it's the best we've got, and I think it's still useful, but take it with a grain of salt that this is not exactly meant to be compared like this. And so if we look here, the blue shaded box is showing the PASI 75 score for all of the biologics, and many of these medication names you'll know very well. And what I want to point out here is that while this does work well, you know, we knew that it outperformed apremilast or Otezla because that's what the trial showed. And we, you know, etanercept is a TNF alpha inhibitor, one of the older ones that we have. But what I mean to show here is that many of the newer medications, like the interleukin 23 inhibitors or the interleukin 17 inhibitors, still, based on this direct comparison, do outperform deucravacitinib. And so I say this so that people understand that this certainly has a place, and for some individuals, it may work better than some of these biologics, right? All of this is based on clinical trials, looking at many, many people and how the average sort of performs here. But we know that for some people, one medication works better than another, even if the clinical trials don't suggest that it is better than the medication that didn't work as well. So I think that's the same for deucravacitinib. And so I think it's an important advance and has a lot of advantages to it. But you know, I do think it's important to kind of keep in mind here that while this is good, effective, and a great new addition to our armamentarium, it is not performing at the level necessarily as some of the other newer medicines we've seen over the past few years on the biologics side. Now, the next question that I think a lot of people think about when they're looking at some of these newer systemic, you know, oral or injection medications is this medicine safe? How does the safety look? And so I will say for deucravacitinib, the safety is overall quite favorable. And you may have heard about certain safety concerns that have come up with some of the other JAK inhibitors. And those medications actually have a black box warning on them for certain safety concerns. They're still very safe, but there are certain concerns that have come up. And because of the difference in the mechanism, a lot of these things we do not think really compare or apply to deucravacitinib, and compared to some of what we've seen with some of the other JAK inhibitors, we haven't seen the same problem. So stay tuned, still new. We have to look at this. We have to follow it over time. Some of the concerns for the other JAK inhibitors didn't come out until we had many, many, many years of experience, but at least early signs are that deucravacitinib is quite safe. The most common side effect in the trials were nasopharyngitis, upper respiratory infections, kind of cold, stuffy nose sort of things. Both were under 10% in the first 16 weeks of study, so quite safe and fairly comparable to the other biologics. We know there's a very low rate of serious infections. Only 14 out of 531 people left the study due to side effects over the course of a year. So quite well tolerated, and vast majority of those who were in the trial with this drug were able to stay on it, and very few had side effects that were severe enough to go off. So really quite favorable safety. And while not yet FDA approved, we also do have some data to suggest that deucravacitinib may be helpful for psoriatic arthritis. And so here is a phase 2, so not a phase 3, but a phase 2 double-blind randomized trial that took 203 people and randomized them roughly a third to get placebo, deucravacitinib 6 milligrams once a day. That's the FDA approved dose for psoriasis, and deucravacitinib 12 milligrams once a day. That's double the currently approved dose for psoriasis. And here's what we see. So in the top panel A, we see that as compared to placebo, many more people and a statistically significant number more people taking deucravacitinib as compared to placebo achieved ACR 20. That is roughly a 20% improvement in psoriatic arthritis. Looking at joint swelling and symptoms, it's a composite score that basically represents 20% improvement. And so you see that roughly 50 to 60% of people in the deucravacitinib group achieve this, whereas under 30% of people taking placebo achieve this. It is interesting to see that deucravacitinib 6 milligrams, which is the currently approved dose, 12 milligrams, were fairly comparable in terms of ACR 20 response. And then below, this is showing sort of a symptom score. And again, we see that as people are on deucravacitinib, that line goes down, meaning they had a greater decrease in their symptom score. They felt better, more so than the placebo group, again, expected. And similarly here, we see that the lines for 6 milligrams and 12 milligrams seem to sort of run together. Looking at the safety, this shows sort of all the safety from the trial, but what I'd like to point out is that it was, again, pretty safe. Roughly 25 to 30% of people had adverse events that were felt to be related to treatment. None of them had a serious adverse event, and very few people, 3 in the 6 milligram group, 4 in the 12 milligram group, left the study due to adverse events. And similar to what we saw in the Poetic trial looking at psoriasis on the skin, the most common side effects were nasopharyngitis, upper respiratory infection. And so the safety was fairly consistent with that trial. And overall, this is a favorable safety profile at this point. So now we're going to move to our next medication, which is Tapinarof, or Vtama. This is a cream. Tapinarof is what we call an aryl hydrocarbon receptor agonist, and we'll look in a second at what that means. It's a new topical medication for psoriasis. It's applied to the plaques once a day. So unlike your topical steroids or calcipotriene or other medications that you may be using 2 times a day, this one's FDA approved and meant to be used only once a day. It was approved in May of 2022, so just over a year ago, and it's sold as Vtama cream. So what is a aryl hydrocarbon receptor agonist? And here's what it is. So this again is showing a cell. The blue box that says TAP in it is Tapinarof, and that red U shape is the aryl hydrocarbon receptor. And so basically the Tapinarof or Vtama goes into cells in the skin, activates this aryl hydrocarbon receptor, causing that to go to the DNA to tell the cell what to do, and results in reducing interleukin-17 activity. And remember from the slide we looked at in the beginning that interleukin-17 activity is sort of the key thing for psoriasis. And so by turning that down, we turn psoriasis down. Interestingly, those who remember or may have heard about the use of tar for psoriasis, which was used more so in the past than it is today with some of the treatments that we now have, this works very similarly to the way tar worked in the past, without the stickiness or unpleasant color or odor. So let's think a little bit about the efficacy of Tapinarof here. First things first, is the composite of two clinical trials called the Soaring 1 and the Soaring 2. And panel A on your left-hand side is looking at a PGA response, which means clear or almost clear to the area that you were using it. And panel B is showing from the second trial. And so in the first trial, the Soaring 1 trial, there were about 35% of people that got to clear or almost clear, or had a decrease of 2 points in that 0 to 4 scale, as compared to only 6% in placebo. And then in the second trial, fairly similar, 40.2% reached that mark with only 6.3% placebo. So you can see that 35 to 40% of people using this medication were able to clear the plaques that they were using it to. This is with just once daily application of the cream. And here's an example of a patient showing someone who went from PGA 4, so that's sort of the highest level that we give at baseline, and you see that this person has what is kind of classic psoriasis, these well-defined plaques with that silvery kind of scale over top. And then at week 12, just a few months later, on our right-hand side, we see that you still see a little bit pink, but these look flat, not scaly. So this gets to a score of 1. That's quite an impressive response, and we see that that's over the person's overall PASI score also decreased substantially. So this is an example of a very good response in a patient with Vtama or Tapinarof cream. So safety for this. It's a cream, but we still look at safety, of course. The most common adverse event was folliculitis, or inflammation of the hair follicles right where you put the medication, and that occurred in about 20% of people in the trials. There was also some contact dermatitis and some stinging that occurred in about 5% of people. Those who have tried Topical or other medications may be used to some stinging. This one caused some stinging and actually even some contact dermatitis, some rash. But generally, it's extremely well tolerated. So now we'll move on to Roflumilast, which is sold as Zoryve. This is another new topical medication that came around almost exactly a year ago in July of 2022. This similarly is applied to the psoriasis plaques daily, and its mechanism is to inhibit phosphodiesterase 4. Some people might recognize that from Otezla or Apremilast, which does this orally. This is a topical medication that does this. So here's sort of a picture of what phosphodiesterase 4 or PDE4 does. There's a molecule called cyclic AMP, here as CAMP, that is turned into AMP by an enzyme called phosphodiesterase 4. When CAMP is turned to AMP, we get a lot of immune activity that is related to psoriasis, including production of tumor necrosis factor alpha, interleukin 17, interleukin 23. They're all the same players that are coming back. These are really the key cytokines, and no matter what sort of treatment you're using at this point, most of them are really targeted right here. Roflumilast blocks phosphodiesterase 4, similar to the way Otezla does, and prevents CAMP from being turned into AMP, which obviously reduces the production of these cytokines, thereby improving psoriasis. So now let's look, again, there were sort of two parallel studies run here, one called DERMIS-1 and one called DERMIS-2. And so these are extremely similar to what we looked at for Tapinarof just a bit ago. Here they call it PGA success, which is, again, clear or almost clear, or a reduction of at least 2 points on that 0 to 4 scale. So it's looking for the exact same thing. And here we see that the Roflumilast group in the first trial, 42% achieved that over an 8-week period. And in the second trial, 37% over the 8-week period. So hard to compare directly. This study looked a little bit earlier than the Tapinarof study, and these percentages are slightly higher. It is not clear that one is necessarily better than the other at this time. They've never been studied head-to-head, and we don't have enough data to do one of those meta-analysis type studies. So there's really no way to know. Obviously, each trial is a little different, so they look fairly similar. It's not clear, even though the percentages are slightly different, that one is truly better than the other. Over time, we may learn that, and one may work better for one person than another. But at this moment, I know the burning question that many of you have is which is better, and we just don't have a good answer at this time yet. So here, similarly, we have some photographs over time. So looking at someone's knee and then someone's axilla, one of the nice advantages to both Tapinarof and Roflumilast is that they can be used anywhere: face, armpits, any part of your skin. And unlike steroids, we don't worry about skin atrophy or worrying about a different steroid that's right for the face, armpits, elbow. You know, we have the same cream here that is safe to be used everywhere. And since it's not a steroid, it does not cause atrophy. And so here you can see that, for example, on the knee, we start with that plaque with that silvery kind of scale on it. And you see that, you know, every 2 weeks we're taking pictures, and it's getting better, and the score sort of marching down. That global assessment score is marching down. Similar in the armpit there, you see that sort of beefy looking plaque there all the way at baseline on the left-hand side. And as we walk from left to right across the screen, we see that it becomes fainter and fainter, and it's essentially gone there at week 8. So two examples of how this can work really well for people. So now let's look at the safety. The most common side effect in the trials was diarrhea, and that happened in 2.8 to 3.5% of people. That makes some sense, right? Because those of us who are familiar with Otezla or Apremilast, which has the same mechanism of action, we know that that can cause some gastrointestinal upset, particularly early on in treatment. So interestingly, even using that as a topical can produce some diarrhea. Obviously not the highest percentage of population, you know, 2.8 to 3.5, but still it happened, and it was the most common. Headaches were seen in about 1 to 4% of people. Application site reactions here were very uncommon. So unlike Tapinarof, this really didn't cause contact dermatitis or stinging really with application. One thing that's worth noting is that actually on the package insert, it says that you should check liver tests. I just want to make a mention of where that comes from. This same medication, Roflumilast, is used systemically for other conditions that have nothing to do with the skin. In those conditions, taking it systemically, not applying it as a cream, but taking it systemically, some people had liver function abnormalities. So it is not clear, and they have not observed people with liver function abnormalities who were taking this Roflumilast as a cream, but it's on the package insert because of what we know about taking it systemically. So it's not clear, and it probably is not going to be as relevant here, but just so you're aware, if you're prescribed this medication, you look at the package insert, that's where that comes from. Overall, very well tolerated medication. Okay, now we're going to change gears a little bit, and we're going to look at a medication that's called Spesolimab. So Spesolimab is an interleukin-36 receptor inhibitor, and interleukin-36 is a new one that we haven't heard of yet, and that's because interleukin-36 is very important for neutrophils, which are the very important type of cell that comes for pustular psoriasis. So for those who aren't familiar, pustular psoriasis is a slightly different flavor of psoriasis that, unlike what you may be most familiar with, which has that sort of very dry scale over it, this actually gets little, what we call pustules, little white bumps filled with pus. They almost look like acne spots, but you get a lot of them, and you can get them kind of all over your body in a big flare, and that can be actually a medical emergency. And those of you who are on the call who have generalized pustular psoriasis that has flared, you know, I don't need to tell you that this can be a really big and scary problem. And up until September of 2022, we really didn't have much that was specifically used for this, and it was very hard sometimes to manage those big flares. So this was a very welcome addition to the armamentarium of psoriasis treatment, particularly for those with this generalized pustular psoriasis variant of psoriasis. So this is sold as Spevigo. It's given as an infusion, so it's not injected the way that most of the biologics we have are injected. It's not a pill, obviously, it's an infusion. So almost like Remicade. it's given into the vein, and it's sold as Spevigo. And here's a picture of it here. Those two little vials are how it looks before it's put into solution to be infused. So the mechanism, as I said, is inhibiting that interleukin-36 activity, which reduces neutrophils, a special kind of cell that's very important for pustular psoriasis. Is a rare variant of psoriasis. So first thing to note at the top of this table is that there were 35 people who got the medication and 18 who got placebo. Since this is such a rare variant, and these flares, thankfully, don't happen all that often over the course of the trial, we don't have hundreds of people. We have tens of people here. So the primary endpoint, which was sort of like the same clear or almost clear score at week 1, but really being clear, we saw that half of patients who got Spesolimab versus only 6% of patients who got placebo achieved this. That is huge for a condition like pustular psoriasis that's so hard to treat. The difference versus placebo you see here was a very big difference, and that p-value shows that it was statistically significant. So really looking at the secondary endpoint, again, almost half of people responded to this. That's a big deal for such a difficult to treat condition. And you see that in both cases, this was clearly different from the experience of those who got placebo. So now looking again at the efficacy, and now we're looking out longer. So we're looking from day 1, which is the 35 people who got Spesolimab at day 1 when they had that pustular flare, looking out 12 weeks. So what happened to them over time? And all of these different lines are showing different measures that we use. And the thing that I'd like to point out here, and I think the most important thing, is that most people, after that one dose of Spesolimab, one time, pretty quickly had a very good response and maintained that response over 12 weeks. That's pretty good. A few people did get a second dose. So with Spesolimab, you give it, and then a week later you check, and if the person's doing well, ideally that's the case, you don't have to give any more. But if the person's still in their flare, a week later, you can give them a second dose. And in this case, 12 of those people had that happen. And even those people kind of caught up and were able to maintain a pretty good response over 12 weeks. So for a condition like generalized pustular psoriasis, this is hugely promising and big news. So let's look at the safety. So by the end of week 12, 82% had an adverse event. Now, we should keep this with a grain of salt because people with generalized pustular psoriasis flares are often actually pretty medically complex and can be pretty sick at that time. Many of those people end up in the intensive care unit. And so, we saw that a lot of people had fevers, but one of the hallmarks of this condition is fever. And so it's not clear that the medication caused the fever. In fact, it's more likely that the fever was part of the fact that they had generalized pustular psoriasis that was flaring. And about 47% of people got infections. Again, slight grain of salt, those are sort of sometimes very overall sick people who may be getting infections more commonly than baseline anyway. And 2 individuals had this condition called DRESS, which is a drug reaction with eosinophilia and systemic symptoms. That's a pretty severe drug reaction. That's something that kind of you have to keep an eye on. But again, understand that generalized pustular psoriasis flares is sort of a medical emergency, and some people are relatively sick at that time. And so even though there may be some risks to this medication, it may be something that's very worth, and in many cases is something that's worth doing, because it can really be a big help and a big savior in a time of real need for someone. So now I'm going to close, and I think we're pretty good on timing, so we have plenty of time for questions here, with a discussion of a medication called Bimekizumab. And many people may have heard about this over a long period of time. It is not yet FDA approved in the United States, but it is an interleukin-17 receptor inhibitor. So we actually have one of these already, which is a medication called brodalumab, or Siliq. This works in a very similar way by blocking the interleukin-17 receptor. So not the piece of mail, but blocking the mailbox, making it so that no letters can come in to the mailbox. It's currently in clinical trials in the US, and there have been a lot of clinical trials done looking at it on its own, comparing it to ustekinumab or Stelara, comparing it to other interleukin-17 inhibitors. It performs really well, and we'll see that in a minute. It's in trials also for psoriatic arthritis and seems to perform there in very effectively as well. If and when this will be available in the US is a bit unclear. The last attempt that the company made at trying to become FDA approved, there were some issues with inspection of the plant where it's made and looking at some things that they needed to alter about their process of making and packaging the drug. And I think they've experienced some delays as related to the COVID-19 pandemic, which changed certain things it's made outside the United States. And so they are still going for FDA approval. It is not clear if or when it will be available, but it has already been approved in the EU. And so people are getting this in Europe at this time. So again here, this is the same image that we saw at the very beginning that we walked through, showing how psoriasis sort of works and the immune process. And I'll direct your attention to the bottom right-hand corner. It says Bimekizumab in red, blocking the interleukin-17 receptor. Again, that Th17 cell and interleukin-17 are really kind of at the heart, the key of psoriasis. And so by blocking the receptor for interleukin-17, you're not allowing messages to come in telling the body to make psoriasis. So now let's turn and look a little bit about Bimekizumab efficacy. And there, as I said, have been many different clinical trials comparing this to other drugs like Stelara, ustekinumab, even to other interleukin-17 inhibitors, and it seems to outperform all of them. This was a trial that was done now a few years ago in 2021 that looked at Bimekizumab, it will be sold under Bimzelx, on its own, looking at the PASI 75 score. So again, that's 75% improvement in your psoriasis, PASI 90 score, 90% improvement in your psoriasis, and then a very high bar of PASI 100, which is 100% improvement in your psoriasis, meaning you are entirely clear of psoriasis at that time. And you see here that it's given once every 4 weeks. That's what those little green arrows at the bottom are showing you. And you can see that at week 16, at 4 months, 95% of patients were 75% clear. That's pretty darn good. Almost 91% were 90% clear, and almost 70%, 68.2 were 100% clear. This is a highly, highly effective medication. Let's look at safety. We know it's very effective. We know how it performed here in this trial. I just told you that it outperformed other medications that we consider to be highly effective in other clinical trials. So now let's think about safety. So the most common side effect was nasopharyngitis, which again is sort of cold symptoms that occurred in 7 to 23% of people, depending on which group you looked at, across 56 weeks. So this is looking out, at 13 months. Oral candidiasis, we know that interleukin-17 is important, 4 to 11% over the 56 weeks. Overall, this is very well tolerated. I think the point here is that the holdup for its approval does not appear to be related to a safety concern that we're aware of at this time. It seems to be other issues. So now, in summary, we talked about a bunch of new medications that have come out for psoriasis over the past year or so. We started with an oral medication called Deucravacitinib, which is the TYK2 inhibitor, a type of JAK inhibitor, and we walked through that and saw that it's safe and effective. We talked about 2 new creams that are used once daily. They're non-steroid. You can use them anywhere on the body. They're quite effective, especially considering that they're creams. They're specifically at this point only approved for psoriasis. And we looked at Tapinarof, which is Vtama, and Roflumilast, which is Zoryve. We then looked at a new intravenous IV infusion medication for generalized pustular psoriasis flares, which was really a big deal for people who are affected by this, because up until that time, it really didn't have anything specific. And this was Spesolimab or Spevigo that we talked about, blocking the interleukin-36 receptor, important for those neutrophils, which are a key cell in generalized pustular psoriasis flares. And then we spoke briefly about a medication that is not yet available in the United States, but is available in the EU, that we're seeing a lot of very promising clinical data for, and we hope that we may see it. It's an interleukin-17 receptor inhibitor called Bimekizumab. So with that, I really want to thank you all for your attention. It's been a true honor to join you, and I look forward, we have plenty of time now to take questions, so I look forward to hearing your questions, and thank you again for having me.
Both interesting, and it was really easy to understand despite all these common names and such. So I've tried to group some of the similar, but summary slide, you know, we have topicals, IV, injection medication. There's some of that is effective if they take an oral.
I'm sorry, could you repeat the question? A bit.
So people questioning if orals are as effective as an intravenous or an injection.
Yes, so that's a very important question. And in general, you know, we looked at that slide where we kind of compared the meta-analysis of the injectable biologics to the efficacy that we saw in the POETIC trial. And what we saw there, again, it's not really a completely fair comparison, but it does not appear that the oral Deucravacitinib, and we know the oral Apremilast, which is Otezla, which we've had for a while, is not as effective as some of the newer injectable biologics. But that doesn't mean that for one individual, it may not be the case that it's more helpful than other medications that you've tried even on the injection side. And so while in general, the answer is no, it does not appear to be as effective to take the oral Deucravacitinib as to take some of the injectable biologics, it's still a meaningful advance, and for some people may be a better solution for reasons of efficacy or other reasons. For example, the fact that it's not a shot might be appealing to some people. People may have reasons why they can't or otherwise don't want to use shots. And so I think it still is a meaningful place, but to answer the question directly, it does not appear that it's as effective as the newer injectables, no.
Summer question, how long is it safe?
You know, that's a really good question, and I'm asked that all the time. In fact, when I tell someone about biologics in my office and they decide they'd like to do it, usually one of the first 5 questions they ask is, how long do I have to be on this for? And I'll say 2 things about that. The first thing is that most people who say that, when they're clear for a while and I say, hey, remember when you said you may want to come off the medication? You know, there's this idea of treat to target, which is used more in Europe than here in the United States, that it may be possible to give people biologics for a period of time, get them to a place where they're clear and clear for a while. And for some of them, you may be able to taper off the biologics or stop it and then only use it intermittently. That's done, again, much more in Europe than it is here in the United States. And so people normally, when they're doing well, kind of have the mindset that they don't want to go off it. So most people are pretty happy staying on it long term. All of the safety information that we have from studies looking at long-term use of these medications suggests that it is quite safe to be on these medications long-term, especially some of the newer ones, which are really quite targeted to the immunologic signals that are important for psoriasis. It appears to be very safe to be on these medications for, you know, decades, which many people do need to do.
Awesome. Okay. Another question we have is, at what point should treatment be started? So do we early in progression?
So this is another very important question that I think our field thinks about a lot. When do you start treatment? I personally am of the mind that if someone has psoriasis, even if it's not very widespread, that's really causing them problems, inhibiting their ability to do the things they want to do, that they are appropriate candidates for biologics. And I think, you know, it's easier to clear less psoriasis than more psoriasis. There is a study and data is coming out that's trying to understand whether using biologics early may prevent some of the comorbidities of psoriasis. For example, does starting a biologic early prevent psoriatic arthritis? It's an active question. We don't know, but it might, or other things, heart disease, etc. And so I am personally of the mind that starting a systemic medication early in the appropriate individual who wants to do it and is motivated to do it is perfectly fine. It is hard to use the creams all the time for some people. For some people, they don't work well. And I think we miss an opportunity to really take care of a lot of people by saying, no, you have to wait until your psoriasis is at such and such a level to start. So that's personal between obviously an individual and their dermatologist when they think it's appropriate to start. But in my view, I actually advocate for starting on the earlier side and sort of taking care of the problem early, as opposed to waiting for it to become a real big impact on life and then stepping in at that time.
Early, we've had some questions about teens to start on the biologics during that age frame, or do they need to wait and older?
No, not at all. Most of these medications are approved for adolescents. Some of them have different dosing for adolescents, but most of them are approved for adolescents. I personally follow many teens who are on these medications. They work well. The teenage years can be, obviously, for many reasons outside of psoriasis, pretty challenging. And if we can effectively take away psoriasis, which may make people self-conscious, may lead to bullying, may lead to mental health issues, if we can remove that from the equation by using a safe and effective medication, I'm all for it. So I do not think you need to wait until you graduate from the teen years. If you're an appropriate candidate as a teen, these are approved, they're studied for teens, and I think it's the right move.
Is there anything specific for treatment of psoriatic nail dystrophy?
Well, many of the biologics, especially some of the newer ones, interleukin-17s, for example, Ixekizumab, or the interleukin-23s, risankizumab, in the trials, they looked at nail disease, and it turns out that these biologics do a very good job on nail disease. So many of the newer biologics work well for nails as well as skin. What I always tell patients is that nails grow slowly. So a fingernail grows out in about 6 months and a toenail grows out in about a year. So you have to be a little more patient, whereas your skin psoriasis may feel like it's melting away in 3 months. That may not be the case for your nails, and you're going to see early changes of nail improvement very close to the bottom of your nail, close to the base of the finger, and it's going to gradually march its way out as the nail grows out. So I also often will have patients who come back and say, I don't think this is helping my nails because the end of their nails are still impacted by psoriasis, but I can often point out that they are beginning to see normal nail growing out, and that time is what you need. So many of these biologics that we use are very effective for nails, but nails can be very challenging to treat, of course, and they respond much more slowly because they grow much more slowly than your skin.
Can Roflumilast be used for genitals?
Yes, it is in fact FDA approved for that. So absolutely, yes, it can, as can Vitama.
Well, that a great comparison we have is the Roflumilast versus the Tapinarof. It works better than the other, or should be paired with light therapy. I was looking for a comparison slide.
So yeah, I don't have a comparison slide because I don't think we really have the data to compare. What I did point out and what I will say is that in the Roflumilast study, they looked at 8 weeks. In the Tapinarof study, they looked at 12 weeks. The Roflumilast study had slightly higher percentages of people responding the way that they were looking for. That might be a slight signal that maybe Roflumilast works a touch better, but they were so close in range, and those confidence intervals, which is sort of our statistical way of understanding how well they work, do sort of overlap. And so it's hard to be confident with the level of data we have now that one works better than another. Although I do believe, and I have seen from experience, that for some individuals, one way may work better than another. In terms of combination, we do that a lot. So I think these medications are good for people who have a relatively low body surface area, but they need to treat consistently. And so they want a cream that they can use all the time, unlike a steroid, for example, that's just one cream once a day for a long term. These are perfect for that. I also pair these a lot with other treatments. So someone's on a biologic, but they have some areas that just aren't responding quite as quickly. They're on Otezla, Apremilast, and some areas aren't responding so quickly. In that case, sometimes it's preference, sometimes unfortunately it's insurance coverage, but I also try to think about the mechanism. So for example, if someone's already on Otezla, I know that Roflumilast, Zoryve, works in the same way. So if I want to pair something with Otezla, I might reach for Vitama first, which works in a slightly different way. Similarly, if someone's on an interleukin-17 inhibiting drug, I might reach for Zoryve before Vitama because that has a slightly different mechanism, hoping that pairing the two mechanisms, one as a cream, one as an injection, will help. So I think that generally people are using these in those two ways, you know, in conjunction with other systemic treatment for sort of stubborn areas that are not responding as fast, and also for people who need a cream that's long-term, but can use a cream alone, these are good for that too.
You care, but they're also curious, why does it take?
I think you broke up.
I go, okay. With the access to care to approve.
I think the question was about insurance approval.
Yes.
Yeah, so insurance approval can be challenging with all these medications. Those of you who are experienced with this know that even with the biologics that we've had for many, many years, we have difficulty sometimes with insurance approval. Your insurance company may have one that they prefer over another. Your insurance company may say you need to jump through certain hoops, try certain medications before you can start using some of these other medications, and so that can be very frustrating. I will say that I practice in Connecticut. Things are different in other places. We have had a problem with insurance coverage for both Vtama and Zoryve, and with the biologics, we consistently have to deal with the prior approval process. That's something that is very frustrating to patients, to doctors. Everybody gets frustrated about it because it leads to significant delay, and sometimes you have to switch because of your insurance, not because of your response, or you have to change the plan to another medicine, again, not because of your ability to do well on a medicine, but because of what your insurance says, even if you and your doctor don't think it's the best. So that rule has sort of continued, or that trend has sort of continued into these newer topicals and also to the newer oral medications. So unfortunately, that's a battle at the American Academy of Dermatology, National Psoriasis Foundation. Many different groups are heavily engaged in trying to fix this for people. But unfortunately, at this point, we're still kind of dealing with that. And for these newer medicines, we are dealing with that.
If you've enjoyed today's webinar and want to learn more about upcoming webinars or events, please subscribe to receive notification of our event. You can watch this event and past on our website there, psoriatic.org/watch and listen. So get to our latest app on your phone and subscribe. Bites. It was really interesting this week. It was called What You Eat Matters. Dietitian Brittany Link from Advice for Eating in Houston. And things to look for on Go to the Market next. If you have any more questions, psoriatic arthritis, or treatment, feel center, the phone, email indicated there on the screen. Reach out and they're happy to give you resources that you may need. So thank you all once again, and we look forward to seeing you.
Thank you for having me, everybody. It's been a real pleasure, and I hope to be able to speak with you again sometime soon.
It was great meeting you and learning a lot from you.
Thank you.